Hello friends, I'm Dr. Amarjit Singh Patwalia from Singh's Eye Center, Punjab. Remember, if you respect the tissues are going to respect you the next morning. So here I'll be presenting a case of implanting a multifocal IOL plus 20 diopters, diffractive IOL with addition 3.5 diopters. Now, why it is challenging in cases of manual SICS? Because most of us, we do SICS either through peribulbar or retrobulbar anesthesia. So in such cases, it's very difficult to mark the visual axis. So we have to play with the Purkinje images. As we go ahead, I'll be explaining you. Now here on the cornea, you'll see a very bright white reflex. Now this reflex is coming from the microscope on the cornea. This is the first Purkinje image. And there is a grayish mark just below it. Now this is the mark which I have made pre-operatively. I have marked the visual axis. Second Purkinje image from the posterior surface of the cornea, which is very difficult to appreciate. And the third Purkinje image is the reflex which is seen on the anterior surface of the lens. Now here we proceed. The incision is 5.5 millimeters, roughly 1.5 millimeters away from the cornea, straight incision. We make a side port, stain the capsule. Friends, not to worry about the capsulorhexis. You can go even up to 6 millimeters. The only thing what matters, small rhexis in cases of toric IOLs. Once you position your IOL, which is centered, now this diffractive lens does not move. It's a fantastic lens. Personally, I love it because of two reasons. One, the halos, starbursts, they are very, very less. And number two, these diffractive lenses, they are independent of pupillary size. Now here we go. This is how we do the rhexis. Now since the incision is about 5.5 millimeters, so I'll be showing you how to bisect the nucleus after delivering the nucleus into the anterior chamber. Once the nucleus is delivered, I'll be showing you the mark which I made on the cornea before the surgery. Now here the rhexis is complete. I don't do hydrodelineation except for the posterior polar cataracts. So this is how the hydrodissection is done. And now putting visco, deliver one of its poles out from the bag using Sinskey hook like this. And now you can dial the nucleus out. Using two instruments, Sinskey and wire vectus, you can just divide the nucleus into two. As you take out one of its pieces, the globe has to be stabilized using Sinskey hook. I'll be showing you. This is wire vectus which goes under the nucleus, and Sinskey hook above. Go very gently, very softly. Now you divide, stable the globe and take out the nucleus. Very easy. Put visco again to avoid damage to the endothelium. Once again, you sandwich the nucleus between these two instruments, or you can use wire vectus alone. Press the posterior lip and the whole piece comes out. Next comes the cortical cleaning. Using Simcoe cannula, you can just clean up the whole cortical matter. Once it is cleaned, I'll be showing you the mark which I've made on the cornea. Here, right, just below this shining dot, you see a grayish mark. Now you can see the rexus margin. The last piece is left, and this can be taken out very easily. Now you can appreciate there's a grayish mark which is there. This is the visual axis. Now this is the IOL, which can be easily put in through 5.5. And here it goes. One haptic is inside the bag. Put a little bit of visco and dial the other haptic into the bag. While implanting the multifocal IOLs, remember to aspirate the visco from above and behind the IOL. Once this is done, then you can center the IOL. Align all the Purkinje images, and they have to be aligned and pass through the bull's eye, which is the center of the IOL. So now most of the visco is out. The antechamber is very neat and clean. Now you ask the patient to look into the light of the microscope. Still, it is not really aligned. I'm not really very happy. See the visual axis which I have marked, the gray, this has to pass through the center. Once again, I have, seems to be a bit okay. Let me just center it right away. I would like to put a little bit of pilocarpine to see the centration of the IOL. Now here comes pilocarpine. Pupil started constricting. So you have to be very meticulous in cases of implanting a premium IOL for premium patients. You have to be result oriented. Otherwise, they'll be after your life all the time. There's a small air bubble. This can be aspirated. Now I am aligning the IOL. Oh yes, it is perfectly centered now. You can see visual axis, the first Purkinje image and third image, they are lying right in the center. So this was the mark which we made, the visual axis. This was also passing through the center. So I think my work is done. So I'll be showing you the first post-op case. Let's see. Yeah, see the cornea is absolutely clear.
ये आंख बंद कर लो.
And here is the patient. Let's see the vision.
आगे
She can read this
आगे D है
6 by 12, 6 by 9, and 6 by
एक लाइन
6.
और अगर पढ़ ली तो वेरी गुड है.
This is the last one, CTPA.
नहीं थल्ले आ C.
And what about the near vision? Let's test the near vision too.
6 by 6 नज़दीक दा देखो ज़रा.
Patient is
इनको
quite
पकड़ लो.
happy. The first post-op day,
पहला अक्षर की है.
vision is 6 by
उन्हें बंद
6.
कर लो.
B T
इथे भी दिखा.
R T M
Last
P.
So she can read very well.
6 by 6.
Very happy. Patient is satisfied.